So we want to talk about the strategic value of IP in the new life science economy. But first, we need to understand a little bit what we mean by new life science economy. And what I'll try to do during this presentation is to look at a different angle from what you may be used to hearing us speak, us IP people. In order to be able to appreciate why IP is becoming increasingly important, not that it wasn't important before, in today's economy, we must first of all understand what has changed, why it has changed, and what those changes means to us. You will see that there are some parts of this presentation that are specifically targeted to the Israeli market, the Israeli companies, not to the Israeli market. But most of the remarks that you will hear in a moment are applicable to companies anywhere in the world. First of all, you all probably know that biopharma companies have been working for the past decades under the model that says we will have 3, 4, 5 blockbuster drugs that will fetch us anything between $1 billion, $4 billion a year, and we will ride on those blockbuster drugs, and we will, of course, have many other products that will go with them, but that is what will keep us going. And what we see now is that in the new economy, this strategy must change. So what is, people ask, what is a new life science economy? And this is part of it. The blockbuster drug for massive disease market model is dead and is no longer a viable way to plan ahead for the next 10 years or so. And it appears that many of the large biopharma companies already understand that, but some companies are not yet there. And we see the writing is on the wall. If, for instance, you look at the stimulus package that was put forward by the Obama administration for 2009-2010, you will see that the focus of investments, of government, of federal investments, is shifting from the development of new drugs to research that intends to improve the effectiveness of the treatment. Just so that we have a few figures, the AHRQ, Agency for Healthcare Research and Quality, has $300 million for that in this budget, in this package. 400 million more go to the NIH, and 400 million more are distributed among various entities for the specific purpose of trying to improve what the treatments do and not to come up with new treatments and new drugs. If we look at the figures of R&D versus new entities that are approved by the FDA, we see that the costs are going up all the time and the number of entities approved are going down all the time. And that is because, again, it is becoming more and more difficult to develop new drugs that are applicable to a very large market. And that brings us to biomarkers. As I'm sure all of you know, the same drug that is very useful for a certain group of patients may be not so very useful for other groups. And there are many reasons for that. Reasons may be related to the age, may be related to gender, but many of them are related to a specific genetic makeup of certain groups. So what's being done now is to identify biomarkers and to use those biomarkers to screen patients for their response to a given treatment, so that if we have a disease that has a broad definition, but has different subgroups defined by those biomarkers, then we know that a given treatment may be very useful for group A and an altogether different treatment for group B. But that's the way we go and try to identify which group will benefit from which treatment. And because our ability to sequence is becoming totally different in a very few years, you see the figures on the slide. The mapping of the human genome took 13 years and $3 billion. And a relatively small US company, Complete Genomics Inc., has published 3 complete human genomes, each of which was sequenced for $4,400 average. And they plan very quickly to be able to make a full sequence for $1,000. That means that each one of us who unfortunately has to find out things about himself because of this or that illness will be able to afford, either directly or through a sick fund, to have this done to himself. And that will be a very valuable tool on the mass market very soon, or at least so that's the projection. So what will happen as we identify more biomarkers? The large disease markets will be fragmented into small niche markets that are identified, are biomarker-specific markets. And the biopharma companies will have to develop treatments that are more specific to biomarker-defined patients. In other words, and I will come to that in a moment, the focus is shifting rather rapidly from the market to the patient. While before a biopharma company thought of us in terms of, oh, okay, there is this illness, now I've come up with this drug that has less side effects or is more convenient to take, it's oral instead of injection, so let's go and sell it to the market because this big market is my market. They will have now to take into account that this big market is made up of segments that have different needs and different responses. This slide is taken from the PwC vision for 2020, and their analysis shows that while today we the patient or the sick fund or whoever is paying for it simply go get a prescription and pay for the treatment, by 2020 the payment will be related to the performance of the treatment that we are getting. So we will not be paying just to get pills that are not so good for us. We will pay proportionally to the quality of the treatment that we are getting. And developing companies have to take that into account now. Essentially, the model says that the patient will be the center of the ecosystem that surrounds health treatment. You probably know Oracle. Oracle is a software company. They don't develop drugs, they don't develop medical treatments. So why are they committed to life science? That may seem at first to be a little strange, but it isn't. Because one of the big things now is patient monitoring and data processing. And just as Eliofer said a few moments ago, the interdisciplinary work between healthcare companies that develop treatments and companies that develop ways to make the treatment more useful is something that is going to be, it's already now here. For instance, if you look at the App Store, I didn't check the figures right now, but the last statistics I had was for February, 2,000 medical applications in the App Store that put monitoring, following the outcome of treatment, and give support to many other parts of the treatment are already in the iPhone. And the few people who don't have an iPhone yet will have it soon, and will be able to get these for 99 cents or $2.99 and have and become much more in control of the treatment that they are undergoing. And this is a small thing because the iPhone is not going to replace the big things. But there is now an opportunity for small and mid-sized companies that is emerging